Thank you very much. Well, it's a fantastic honor to be here, and this is, I'm not sure why I was chosen for this subject, but I actually know quite a bit about this. And I've worked with the company some. I've never taken a cent from them purposely. I was asked to independently review some of their data, and I'm going to tell you, you need to know about this, this device, and it's going to have a role. And the question is, what is the role? So we're going to go a little bit through this, and the concept of the E-valve is the Alfieri stitch, and many of you know Professor Alfieri, who's a very good guy, and I must say I used this particular technique, the Alfieri stitch, probably a dozen times with mixed results. I was not very impressed with it, and Professor Alfieri himself will use it only in conjunction with a ring. So you might say, well, if it doesn't work in our hands where we put it in directly, how in God's name is it going to work, you know, by some cardiologist putting a clip somewhere? But this is a device, and it's a very clever device. It's a clip that's put in under echo guidance, and it's not something that every angioplasty cardiologist can do. We at UVA, I think, have at this point the biggest experience in the U.S. with this, but particularly because of Scott Lim, and Scott is a pediatric cardiologist by training, and he's really become a true structural cardiologist. And this is complex technology, and the fact is, many of these were put in by Scott, and I'll show you that we're involved in this pretty heavily at this point too. So this is what we're going to talk about. Everest 1 is a non-randomized, just basically, could this be done at all? Everest 2 was a pre-randomization. Then there was essentially the randomized 2-to-1 clip to surgery, where we did participate, and several other centers in the U.S., which is a 2-to-1 clip to surgery. And then there's a continued access, and this has actually been a complex issue for us because patients want this. They think it's like a brilliant technology. And I'll show you, it's in fact pretty easy on patients. And then there was a high-risk trial as well, and I'm going to spend a moment or two talking about that. So this is what the randomized trial looked like. 184 clip patients, and there were 95 surgical repair. I would say the surgeons who did the repairs, you know, were what you consider good mitral surgeons. And to qualify, you had to have a large mitral valve experience. You had to have certain results. So this wasn't comparing this to someone who's put three mitrals in the last 12 years. I think this is a legitimate approach. And so the inclusion criteria, and this is important, and they were forced to do this by the FDA. Where the company originally came to was to talk about, is this proper for high-risk patients, people that we would rather not operate on? And in fact, the FDA forced them to basically do an all-comers kind of study. And I think you'll find, and if you remember nothing else, that probably this will work for some high-risk patients. I think would be a fair final conclusion. But you had to have significant mitral regurgitation. You had to be symptomatic or asymptomatic with evidence of pulmonary hypertension or atrial fibrillation. The exclusion criteria were specific in many of the things that we would say. You know, rheumatic heart disease. In the States, I would say the approach is not to repair regurgitant mitral valves, but to replace them. And there are certain exclusion criteria related to how much coaptation, where the jets were, things of that sort. Things that I would say we could repair as surgeons that perhaps they cannot. And this is a busy slide, but the bottom line is they looked at various comparisons of, you know, these are essentially relatively young patients. Most were class 3 or 4, and you know, by definition, these are pretty good ventricular function patients. These are not people with functional MR. The etiology or degenerative or myxomatous disease, the majority being, you know, posterior prolapse, and some with some anterior leaf disease. There's just a few functionals in this category. And so the question is, why would this work at all? And the reality is, remember, for these guys, they're put in exactly where the echo jet is. When we operate, put an Alfieri stitch in, we have an arrested heart. We have some concept or feel for maybe where this has to go. And if we can repair something, we do. So it's a little bit different subset of patients. And they looked at a bunch of safety issues and effectiveness issues. Now remember, by definition, They considered a success if they had 2+ or less mitral regurgitation. We would be shot on sight if we left the operating room with 2+ mitral regurgitation. But that was what the what was agreed to by the FDA. And this device is not meant to completely abolish mitral regurgitation, and certainly cannot do nothing for the annulus, and probably can't do much for multiple jets. But having said that, this is what ended up shown. So they looked at both safety and effectiveness, and it's a safe device. There was essentially no mortality there, and we can argue, surgeons, what they called about effectiveness. We can argue what we would control adverse events, and I'll show you this. And just so you understand what the conclusions are, you have to understand the language that this device is using. And there were no deaths with the device, and in fact, the majority of people go home that day or the next day. There's no question, that it's a reasonable thing. In the group itself, there was no reoperation on the mitral valve right away. Now, this is a little bit odd because obviously many of these patients come back a month or two later, and it's not quote unquote a procedural failure. And I think it's important, if you look at what the adverse effects for the surgical group, 42 had evidence of some blood transfusion, so that's 50% of our complication rate. The fact is that both procedures were reasonably safe, and both procedures, worked reasonably well. In terms of 12 months endpoints, there was 4.5% died in the device group and 6% of the control group, which I would have guessed was kind of high for elective mitral valve surgery. And in terms of mitral valve surgery for the device groups, 6.7% got operated on, and very few of the controls were operated on. At greater than plus 2+, 16% of the device group, but virtually all of them had 2+ mitral regurgitation, and very few of the control group. And clearly surgery was superior in terms of prevention of mitral regurgitation. And this is a kind of a busy slide, but if you look at this in terms of the device group, if you look, essentially 60% of the patients had more mitral regurgitation than we would leave the operating room with, and surgery in fact did pretty well for that. They did a bunch of stuff like LV volumes and things like that, and there is some evidence of some remodeling for these patients. I'm not going to spend much time on that. And the majority of patients in both cohorts felt better after they're done with surgery. And there's a place for this. For example, a personal friend of mine is an 88-year-old retired surgeon who had a previous bypass 8 years ago. He had 4+ mitral regurgitation. He's extraordinarily frail. And, it would have been hard to start an IV on him, let alone do a reoperation. And he got the device, went from 4+ to 2+ MR, and work feels perfectly fine. And so there's no question that it can be done safely with some efficacy. This is freedom from death, at days from procedure, about 3 years, and freedom from mitral valve surgery. And they do better than you think. We worry because when you leave the OR, if you leave the OR with 2+, it's 3+ by a month out. And this looks like it's reasonably constant. But then again, by definition, remember, these are fully loaded patients in the cath lab, as opposed to when we arrest them and anesthetize them the way we do. So in summary, it's, their safety and effective endpoints were met if indeed you understand the definitions of what the efficacy is, 2+ mitral regurgitation. And this clinical success rate at 12 months is 70% for the MitraClip and nearly 90% for surgery. And one of the issues, surgery remains an option after the MitraClip procedure. And we're going to talk about that for a moment or two because it's a critical point, because the device and the cardiology investigators would like to tell you that they put this little clip in, it works fine, but then you can easily repair it if it doesn't work. And that may or may not be true, and I'll show you some data about that. The high-risk study, I'm just going to spend a moment or two on this, is a totally different crowd, 78 enrolled. Most of them are functional MR, dilated cardiomyopathy, and then they had a concurrent control group. These were truly patients who were considered inoperable. You had to have 2 surgeons say that they were inoperable to be considered that way. And the actual mortality for 7%, The surgical mortality, these are sick people, 20%. And the control group, the same deal. This is, in terms of 30-day results, 82, percent success, and 12 months, 74% of reducing to 2+ or less. So not too bad. And in fact, I'm going to suggest this is where this device is going to end up, at least in the short term. And this is heart failure hospitalizations. Again, if you look at, it definitely reduced it compared to control groups. And this would happen in the New York Heart Association class. And it did have sustained symptomatic improvement in this rather high-risk group of patients. And they had improved 1-year survival compared to the concurrent control group. So again, it demonstrates superior safety compared to estimated risk for surgery. The clinical benefits were sustained at 12 months. And for many of these patients, 12 months is pretty much what you're going to get out of them. And they had some reverse LV remodeling. And you'd say there aren't that many of these patients. Believe me, once you become a center for this, they come out of the work. I mean, Lars will tell you, you cannot imagine how many of these people there are out there. And the fact is that it increases your own mitral valve surgical patients because many of them don't meet the criteria for the procedure. We really believe that this is the way you have to go. It's about collaboration. All these patients are seen in conjunction with the surgeons. Gaurav Alawadi on my right in this slide is one of our younger faculty, and he's become quite expert at putting this device in. And this is a game we're going to need to play, folks. I'm just going to tell you. And we're not bad at this, and I'll show you some data. Scott Lim is this guy over here, and he's actually terrific to work with. And so what we did a study we presented at ATS last year just to see if surgeons could do it. Now, Scott is very good at this. I would say he's as good as anyone in the country. He's done it a lot. He gets it. He can do transatrial approaches easily. This is something that's more complicated. And basically, within 2 or 3 cases, Gaurav could get basically the times, and with Scott's help, to do this procedure. And now our fellows are involved, and so this is a hand-in-hand thing. One of my other partners, John Kern, is starting to do them as well. And that's the way it looks at. So my conclusion, mitral valve repair with a MitraClip can be performed by interventional cardiologists or cardiac surgeons with good outcomes and low complication rates. And you can definitely reduce the times. And I do believe there is a role for this device. There are patients we really should not operate on. If you look at mortalities with the true functional MR from dilated cardiomyopathy, we do not impact their survival. There have been multiple studies, despite 5-year survival rates the same with surgery versus medical therapy in those patients. Now, we can make them a little bit better, I believe, and you can certainly put rings on those patients with perhaps 5% or less mortality. But if this device works for that crowd, I think it's a good thing. I want to mention a word or two just about reoperation rate. Mike Argenziano published a paper with many of us on basically about a 30% reoperation rate for the original cohort. And the vast majority could be done with repairs, no question about. Perhaps many of them, the clip just never went on, and so that makes it very simple. The problem is that there's a change in the technology such that we now know if you put 2 clips on, you perhaps can, get a better result and have less recurrence rate. Problem is, when you put 2 clips on, it's going to be much harder to repair them. So I'm not sure that these were going to be repairable valves in all cases if it doesn't work. And I think we're going to have to get clever at this because this thing will eventually get approved by the FDA. I suspect, I don't know where it's at in Europe right now, but you can tell me. But it's technology you need to be familiar with, whether or not you put them on yourself, but certainly if and when you have to go back and repair them. Anyway, I appreciate your attention.